Hello, my name is Osama Naga. This is the last part of the renal disorders. Check the third edition for all updated information. Nephrogenic diabetes insipidus, it is because of insensitivity of the distal nephron to antidiuretic hormone. So the distal nephron is not sensitive to the antidiuretic hormone, so regardless the serum osmolality, the kidney will keep losing water, and this will cause polyuria, so the urine osmolality will be very low. And because of loss of too much water from the kidney, the body will be in a state of dehydration, and the serum osmolality will be elevated, associated with hypernatremia and a high sodium level. 90% of the cases is X-linked recessive. Secondary forms can be because of drugs or medication, nephrotoxic drugs, chronic pyelonephritis, obstructive uropathy, or sickle cell trait. It is very difficult to diagnose diabetes insipidus in general in infants and children because of non-specific presenting features like poor feeding, failure to thrive, irritability. So you need high index of suspicion to be able to diagnose this disease. Failure to thrive because they prefer to drink more than eating good calories. Constipation. Breastfed infants, they have delayed diagnosis because of low solutes in the breast milk than the formula and less hypernatremia. Irritability because of borderline dehydration. Intellectual disability because of hyperosmolarity in the brain, and this can shrink the brain cells and put them also at high risk of hypoxia and seizures as well. ADHD-like symptoms, which is similar to irritability. Red flags can help you to detect this disease early, like if you have a child with inability to toilet train, frequent daytime accidents, constant thirst, the child is always thirsty, and if you do ultrasound, the bladder is very dilated because of high volume urine output.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
Diagnosis of nephrogenic diabetes insipidus, urinalysis and blood test. You do urinalysis, you will see the urine specific gravity or urine osmolality is very low. And vasopressin test is a simple test. You give vasopressin intranasally and you collect the urine before and after. You will see no effect in urine concentration. Why? Because the vasopressin is not working in the kidney. The kidney is not sensitive. But in cases of central diabetes insipidus, if you give vasopressin and you collect the urine before and after, you will see the urine become concentrated. Why? Because the kidney is healthy, but the problem is central deficiency of ADH or antidiuretic hormone. If you do blood test, you will see hypernatremia. The serum sodium will be very elevated. It can be as high as 170 mg per liter. High serum osmolality more than 300. If you do plasma ADH, level will be normal or high. In cases of central diabetes insipidus, the ADH will be low or absent. The treatment, very important to allow these children to free access to water all the time. If you restrict water, simply they will die. You have to allow them to drink water all the time. You cannot restrict water from a child with diabetes insipidus in general. Treatment, you do low sodium and protein diet, thiazide. The thiazide will decrease the solute or the electrolyte reaching the distal nephron, and as a result of that you will decrease the water loss. Indomethacin will decrease the glomerular filtration rate, and at the same time will decrease the sodium to the distal nephron and decrease the water loss. Very important to remember, allow free access to water all the time. Bartter syndrome is a genetic disease because of inability of the kidney to concentrate the urine, with excessive loss of water, sodium, potassium, chloride, and calcium in urine. This disease can present early, even before birth, because of excessive urination in utero, and can cause polyhydramnios. If the baby is born, you may see dysmorphic features with large eyes and a triangular face. Also, these infants or newborn, they will have polyuria, polydipsia, failure to thrive because of dehydration, associated with normal or low blood pressure. This is a key word for this disease. Why? Because they have high level of aldosterone, and normally when you have high level of aldosterone, the blood pressure will be elevated. But in this disease, they will have high level of aldosterone with normal or low blood pressure. If you measure their electrolytes in the blood, you will see hypokalemic, hypochloremic metabolic alkalosis, hypercalciuria, and this can cause kidney stones and also can cause tetany because of low serum calcium, high level of renin, aldosterone, and prostaglandin E, low serum magnesium in 30% of the cases, and a high level of urine chloride. Treatment to prevention of dehydration, correction of hypokalemia with potassium supplementation, anti-aldosterone medication like spironolactone, angiotensin II antagonist, ACE inhibitors. This is very important, the treatment. Indomethacin for decreasing prostaglandin E, growth hormone for a short stature, calcium or magnesium supplementation in cases of tetany. Whenever we mention Bartter syndrome, we need to differentiate that from Gentleman's syndrome. The age of presentation, Bartter's can present prenatally with polyhydramnios, neonatal, and early infancy. Gentleman's presents late childhood, adolescent, or adult age. Clinical presentation, polyuria, polydipsia, vomiting, constipation, salt craving, volume depletion. In cases of Gentleman syndrome, they present with more muscular cramps, numbness, fatigue, irritability. Growth retardation is common with Bartter syndrome, is not with Gentleman's syndrome. Metabolic effect, they are the same: hypokalemic, hypochloremic metabolic alkalosis. Urine calcium is very important. Differentiating point between Bartter's and Gentleman syndrome is normal or high. In urine calcium is normal or high in cases of Bartter, similar to effect of loop diuretics, and is low in cases of Gentleman syndrome, similar to the effect of thiazide. Magnesium level is low in 30% of the cases of Bartter, but always low in Gentleman syndrome. Urine prostaglandin is high, is normal in cases of Gentleman syndrome. Location of the location of the defect or the genetic defect in Bartter syndrome in ascending lobe of Henle, in case of Gentleman syndrome in distal tubule. Polycystic kidney disease, we have two forms: autosomal recessive and autosomal dominant. Autosomal recessive polycystic kidney disease presents before birth with oligohydramnios and less amniotic fluid. And this can cause pulmonary hypoplasia and powder fishy ears, low set ears, micrognothia, flattened nose. If you do ultrasound or you do the physical exam, you will see bilateral flank mass during the neonatal period or early infancy. Will be associated with portal hypertension and will cause ascending cholangitis, hypersplenism, progressive liver dysfunction. Autosomal dominant presents most commonly in adult life with gross hematuria, bilateral flank masses, hypertension, and UTIs. This disease can affect the liver, pancreas, spleen. So you may see cysts in the liver, in the pancreas, spleen, ovaries, and intracranial aneurysm. Absence of family history, this disease is autosomal dominant, but absence of family history does not preclude this diagnosis because it can be just a spontaneous mutation. So if you have a child or a family history of autosomal dominant, you need to monitor the children for development of this disease. Nephronophthisis is a genetic defect in the kidney causing medullary cystic dilatation, and it presents early in childhood with polyuria, polydipsia, fatigue, anemia because of erythropoietin deficiency, failure to thrive because of dehydration initially, then afterward because of renal insufficiency. Red flags for this disease to pay attention: polyuria, excessive thirst and fatigue. Think about this disease. Polyuria or excessive thirst and fatigue. Think about nephronophthisis. This is a dangerous cystic kidney disease with no cure, progress to end-stage renal disease around age of 13 and require transplant or renal transplant or dialysis. associated with extra-renal manifestations, for example, ocular motor apraxia, or inability to move the eye horizontally, retinitis pigmentosa and vision loss, coloboma of the eye, ataxia, and this well known as Joubert syndrome, also can be associated with other syndromes. Renal ultrasound shows loss of corticomedullary differentiation, and if you do renal biopsy, will show cystic dilation of medullary collecting tubules. Lawrence-Moon-Bardet-Biedl syndrome is an autosomal recessive disease associated with obesity, retinitis pigmentosa, which is night vision loss and can progress to central vision loss and complete blindness, hypogonadism, polydactyly, mental deficiency, cystic dysplasia of the kidneys. Multicystic dysplastic kidney disease. In general, renal mass is the most common cause of abdominal mass in a newborn. The first most common is hydronephrosis. Multicystic dysplastic kidney disease is the second most common. Usually diagnosed on prenatal ultrasound. And after birth, if you are taking care of this newborn, you will be able to feel a mass on one side. Of course, bilateral is incompatible with life and will cause fetal demise. Once the baby is born and you feel a mass on one side, or the OBGYN notified you with multicystic kidney disease or possible multicystic kidney disease, you need to confirm with renal ultrasound. Then if the diagnosis is confirmed, you need to do a VCUG. Why VCUG? Because there is a 30 to 50% chance that the other kidney may have reflux. So this infant or child will live with only one kidney, so you don't want to risk this kidney at all. Then you need to perform a serial renal ultrasound. Why? You want to make sure that this kidney is decreasing in size. The dysplastic kidney is decreasing in size. If this kidney starts to grow, you have to refer to urologist for nephrectomy. Why? Because it has immature cells, and these immature cells may become malignant. You need to reassure the parents that this child will have normal life, or this infant will have normal life expectancy. You need to advise them to avoid contact sports because of trauma, and is only one kidney. You don't want to risk this kidney. We'll start a new section, acute renal failure. The new name is acute kidney injury. Acute kidney injury means rapid decline or abrupt decline in the renal filtration function, and this will lead to rapid rise in the serum creatinine, azotemia or increased blood urea nitrogen, and oliguria or decreased urine production. Causes of acute kidney injury classified to pre-renal, post-renal, and renal. Pre-renal acute kidney injury can be caused by any factor affect the blood flow to the kidney. So decrease the blood flow to the kidney will cause pre-renal acute kidney injury, like in case of hypovolemia or hypoperfusion. The most common cause in children, gastroenteritis and dehydration. Other causes like heart failure and sepsis. Post-renal is because of obstruction to the collecting system of the kidney, like in case of congenital anomalies in the ureter or urethra. Renal causes, which is direct injury to the kidney or the parenchyma itself, like in case of hemolytic uremic syndrome, rhabdomyolysis, aminoglycosides. Let's understand how pre-renal acute kidney injury develop. If you remember, is because of decreased renal blood flow. Decreased renal blood flow will decrease the GFR. Causes of decreased blood flow or renal blood flow to the kidney like hypovolemia, dehydration, or hypoperfusion, like in case of heart failure, shock, sepsis, anaphylaxis. All these factors will decrease the GFR. And when the GFR is decreased, the kidney start to react, will stimulate the renin-angiotensin system. And this system will release aldosterone. The aldosterone will go and work on the healthy renal tubules by increasing the sodium reabsorption. And as a result of that, you will have low urinary sodium. You will have less FeNA, or fractional excretion sodium will be less than 1%, or low urinary sodium less than 10. But along with the sodium will be also water. So the kidney will reabsorb more water and will be able to concentrate the urine. At least remember, the urine will be concentrated. The urine osmolarity will be high. More than 400 in older children, more than 350 neonates. So remember, low urinary sodium and concentrated urine or high urine osmolarity, because the kidney is healthy, is able to concentrate the urine. So the aldosterone will take more water, and with the water will go more BUN. So the BUN will be increased in the blood. So in this case, the BUN to creatinine ratio will be more than 15. Normal is 15. In this case, will be increased. So finally, remember that in pre-renal acute kidney injury, you will have the BUN to creatinine ratio is increased, low urinary sodium and high urine osmolarity. Why? Because the renal tubules is healthy and the aldosterone is able to work on it with no problem. If you do not treat these children on time, this will cause damage to the renal tubules and will move from pre-renal to renal acute kidney injury, and the problem will be worse, and all these numbers will change. Let's learn together the idea of post-renal acute kidney injury. It's because of obstruction, and this obstruction will cause increased backflow. The pressure will increase, so the kidney start to fighting to filtrate against backflow pressure coming because of obstruction down below in the downstream of the kidney. So here you have back pressure, and this will decrease the filtration, glomerular filtration or GFR. And what happened here, this will force more BUN to go to the blood, and this will explain why the BUN to creatinine ratio will be elevated, will be more than 15. Normal is 15. And the renal tubule is still healthy. Even with this obstruction, the renal tubule will be able to absorb sodium, and this will explain why the sodium or urinary sodium will be low, less than 10, and the fractional excretion sodium will be less than 1%. Also, the renal tubules are healthy and is able to reabsorb more water and will be able to concentrate the urine. So the urine will be concentrated, and the urine osmolality will be more than 400 in older children, more than 350 in neonate. Of course, again, long-standing obstruction can cause damage to the renal tubule, and this will change all these numbers again. So early treatment is critical. After understanding pre-renal and post-renal acute kidney injuries, it will be very easy for us now to understand renal acute kidney injuries. This can be caused by either ischemia or nephrotoxicity. Either way, this will cause eventually injury and necrosis of tubular epithelial cells. So you have injury and necrosis of the tubular epithelial cells. This will impair the function of renal tubules. In this case, you will have impaired or decreased the reabsorption of BUN, and this will decrease the ratio of BUN. So you will have decreased BUN to creatinine ratio less than 15. Normally is 15. Also, the renal tubules are damaged, and this will affect the absorption or reabsorption of sodium, and this will be associated with increased urinary sodium. So you will have the FeNA more than 2% and a high urinary sodium. Also very important to know that damage to the renal epithelial cells will cause death and sloughing of the epithelium of the renal tubules, and this will be casted in the renal tubules in the shape of the renal tubules, and will be urinated out on form of granular muddy brown casts. And this is explain why we have muddy cast or brown cast in cases of renal acute kidney injuries. Finally, remember about renal acute kidney injuries associated with low BUN to creatinine ratio, high urinary sodium, more than 2% in older children, more than 2.5 to 3% in neonates, and the urine osmolality will be low. The kidney or the renal tubule cannot concentrate the urine, not able to concentrate the urine. Why? Because they are damaged. So the urine osmolality will be low, will be less than 350. So remember that, and this will make it very easy for you to differentiate between these three conditions. To summarize the last few slides, in cases of pre-renal acute kidney injuries and post-renal acute kidney injuries, the kidney will be able to concentrate the urine. So because the renal tubules are healthy, so you expect to see the BUN to creatinine ratio is elevated, is more than 20, and FeNA is less than 1% in older children, less than 2% in neonates, and urine osmolality is elevated. In cases of renal, because the renal tubules are damaged, you expect to see that the BUN to creatinine ratio less than 15, because the kidney cannot concentrate the urine. The kidney will lose a lot of sodium, so you expect to see in the urine FeNA is more than 2% in older children and more than 2.5% in neonates, and urine osmolality is low. Both cases, they present with azotemia, increased BUN or blood urea nitrogen, high serum creatinine, and oliguria or decreased urine production. To emphasize on the difference between pre-renal acute kidney injuries and renal or intrinsic acute kidney injuries in pediatrics, urine specific gravity in pre-renal will be elevated, will be low in cases of renal. Urine sodium will be less than 20 in cases of pre-renal. Urine sodium will be more than 40 in renal. FeNA will be less than 1% in pre-renal. FeNA will be more than 2% in renal causes or intrinsic causes. For neonates will be less than 2%, will be more than 2.5% in cases of renal. Urine osmolality will be elevated, and urine osmolality will be low in cases of renal or intrinsic acute kidney injuries. BUN creatinine ratio more than 20, and in cases of renal or intrinsic is less than 15. I use the number less than 15, more than 15, just to make it easy to remember, but in pediatrics generally will be more than 20. Very important for us to understand the staging of acute kidney injuries. Failure of the kidney if the serum creatinine more than or equal 300% of the normal value, or more than or equal 4 mg per deciliter, or if the patient in dialysis. Also decreased urine output by 75%, or less than 0.5 ml per kilo per hour, or anuria more than 12 hours. This is all a failure of the kidney. If this problem persists more than 4 weeks, this is loss of kidney function. If this problem persists more than 3 months, this is end-stage kidney disease. Diagnosis of acute kidney injury, history and physical exam is critical to be able to narrow your differential and to be able to order the appropriate lab. In general, oliguria is less than 1 ml per kilo per hour. General labs, BUN and creatinine, electrolytes, and you can do that by just ordering BMP. Urinalysis and urine sodium is very important to be able to determine if it's pre-renal, renal, or post-renal. Other labs according to the differential diagnosis. Renal ultrasound will show the anatomy of the kidney, and also will show if there is any congenital anomalies, enlargement of the kidneys. Kidney stones also sometimes can show with the renal ultrasound. Management of acute kidney injury prevention is the most important step. For example, if you are prescribing medications to the parents, teach the parents about the possible side effects of these medications. If you are giving, for example, simple ibuprofen for fever or pain, teach the parents to keep the child well hydrated. Do not overdose the child because of fever. Fever is not dangerous. Very important, if you are in the hospital and giving gentamicin or vancomycin, you need to monitor the level. Use the lowest effective dose. Adjust the level to prevent kidney toxicity. Fluids, very important to keep the child well hydrated. In cases of dehydration or shock, follow the PALS. Give boluses in a short time, in minutes, and repeat the boluses as necessary. The most common fluids are used in cases of PALS or shock, sodium chloride or normal saline. Also, you can use lactated ringers and packed red blood cells. 20 ml per kilo generally used, and 10 ml per kilo if the cause is cardiac. Management of acidosis is critical, and this can even manage the hyperkalemia. Monitor the heart for the effect of the potassium in the heart, and look at the T wave and the QRS. Also, you can, in symptomatic cases, you can use insulin and glucose. Use diuretics, renal replacement therapy, like for example peritoneal dialysis or hemodialysis. Indications for renal replacement therapy: if it's volume overload, if it's 20 or 10 to 20% fluid excess, severe acidosis, hyperkalemia, uremia, BUN more than 100 mg per deciliter, or if the child is symptomatic. Be familiar with the keywords and differential diagnosis for intrinsic or renal acute kidney injuries. If you have a patient with muddy, brown, granular cast, this is a keyword for acute tubular necrosis. Acute tubular necrosis is commonly from transformation of pre-renal acute kidney injuries. Common medications associated with this condition is aminoglycosides, methotrexate, amphotericin, intravenous contrast, toxin-mediated like myoglobinuria. So treating pre-renal condition on time, you may save the patient to develop this condition, acute tubular necrosis, and damage to the renal tubules. If you have a patient with hematuria, dark brown urine, tea-colored urine, hypertension, developed 2 to 3 weeks after URI or streptococcal infection, this is post-infectious glomerulonephritis. In this case, C3 will be low and C4 will be normal. If you have a patient with gross hematuria 1 to 3 days or during URI or upper respiratory tract infection, this is IgA nephropathy. If you do C3 and C4, they will be normal both. If you have a patient with arthritis, discoid rash, malar rash, photosensitivity, serositis, this is lupus nephritis. In this case, ANA will be positive. Anti-double strand DNA will be positive. C3 and C4 both will be low. Other keywords for possible causes of intrinsic acute kidney injuries: hemoptysis and positive anti-glomerular basement membrane antibodies. This is Goodpasture syndrome. If you have a patient with sinusitis, epistaxis, and positive C. ANCA, this is granulomatosis with polyangiitis. The former name is vagunar granulomatosis. If you have a patient with lung involvement and positive P. ANCA, this is microscopic polyangiitis. If you have a patient with sinusitis, asthma, skin findings of, for example, palpable purpura, eosinophilia, and positive P. ANCA, this is eosinophilic granulomatosis. The former name or the famous name is the Churg-Strauss syndrome. Now the current name is eosinophilic granulomatosis. If you have a patient with progressive loss of renal function in a short time, this is considered a medical emergency, requires renal biopsy. If the renal biopsy is positive for crescents, this is rapidly progressive glomerulonephritis. If you have a patient with fever, eosinophilia, and rash, and the urine is positive for eosinophils and positive for white blood cell and red blood cell counts, these are keywords for allergic interstitial nephritis. Allergic interstitial nephritis can be associated with systemic disease. For example, Sjogren's syndrome, sarcoidosis can be also a result of rejection of renal transplant. So remember the keywords for this disease: fever, eosinophilia, and rash. Triads: fever, eosinophilia, and rash associated with renal failure. This is allergic interstitial nephritis. If you have a patient with bloody diarrhea, anemia, thrombocytopenia, high LDH, schistocytes, or helmet cells in the peripheral smear, this is diarrhea positive hemolytic uremic syndrome because, for example, of Shiga toxins produced from the E. coli. Anemia, thrombocytopenia, high LDH, schistocytes in the peripheral smear, and is not with diarrhea. This is diarrhea negative hemolytic uremic syndrome. In these two conditions, you will have high BUN and creatinine. Nocturnal enuresis, the new name, primary monosymptomatic nocturnal enuresis. Family history or positive family history is very common. If one parent had nocturnal enuresis, the chance is high. If both parents had nocturnal enuresis, the chance is even higher. Very important to know the difference between boys and girls. This disease is more common in boys, but in generally, boys are very common to be continent day and night after age of 8, and the girls, they are continent day and night after age of 6. So this is very important to know for reassurance. Nocturnal enuresis is a diagnosis of exclusion. You need to exclude all organic causes and other causes of enuresis before you come to this diagnosis, nocturnal enuresis. So careful history of fluid intake at night, daytime voiding pattern, make sure it is at night only, not during the day. Number and timing of episodes of bedwetting. First test to do urinalysis. If you see glucose in urine, you need to do full workup for diabetes mellitus. If you see low urine osmolarity or low urine specific gravity, this makes you suspicion of diabetes insipidus. If there is a high white blood cells in the urine or positive urine culture, this is UTI. This is very important to do before you come to the diagnosis or start treatment for nocturnal enuresis. Very important to be familiar with the differential diagnosis of nocturnal enuresis. History and physical examination is the key for the correct diagnosis and the proper treatment. The first one is overactive bladder, very sensitive bladder. So children with overactive bladder or dysfunction, they are always irritable, they are standing on tiptoes when they have the desire to go to the bathroom, crossing legs, squatting with heels pressed into the perineum. Neurogenic bladder because of neurological damage. Small bladder capacity, the bladder is too small, cannot hold too much urine. Excessive urination at night, nocturnal polyuria, cystitis infection. Sleep apnea, obstructive sleep apnea, very important to know that can be associated with nocturnal enuresis. So if you remove the adenoid, if you remove the tonsils and no more sleep apnea, this will correct the nocturnal enuresis with no further treatment. Major motor seizure or seizures can be associated with nocturnal enuresis. Ectopic ureter, the key here that the child never dry, always wet. Constipation, diabetes mellitus, of course, and diabetes insipidus. So again, history, physical examination is the key. Nocturnal polyuria means excessive urination at night. If the urine production at night is more than 130% of the child's expected bladder capacity. How you can calculate the EBC? The EBC equal 30 ml plus age in years times 30 ml. This will give you that. So if it's more than 130% 30%, this will give you the diagnosis of nocturnal polyuria. Small bladder capacity, also the same calculation, frequent small voids during the day and of course at night. Treatment of nocturnal enuresis. Step number 1, to reassure the parents that this condition is self-limited and most of the children will grow out of nocturnal enuresis. You need to exclude all other causes before you start treatment of nocturnal enuresis. Fluid restriction in the evening is moderately successful, but it's very important to keep the child well hydrated and encourage fluid intake during the day. Just restrict in the evening. Acute treatment should be avoided before age of 6. Motivational therapy, avoid punishment and reward for dry nights. Reward for dry nights is very effective. After doing all of that, the first line of treatment is conditioning therapy, bedwetting alarm. So what happened here, there is a sensor attached to the underwear and there is an alarm. And when the sensor become wet with the first few drops of urine, the alarm will start and will wake everybody in the house. So it's very loud and the parents, as soon as they hear the alarm, they should go to the child room and lead the child to the bathroom, okay, and to let the child urinate. Then we'll take the child back and the child has to help with changing the bedding before goes to sleep. And you do that for 8 to 12 weeks in order to see effect. After that, successfully, this can make the child dry at night and treat nocturnal enuresis. After 12 weeks or more, if this is not successful, you go to the next step, desmopressin. Desmopressin is antidiuretic hormone, will decrease the urine production at night because it will be given only at night. So very important to advise the parent, no drinking water whatsoever after taking the medicine. Why? Because this will cause retention of the fluid, and as a result of that, it will be associated with hyponatremia if the child keep drinking water after taking the desmopressin, because the kidney will not produce enough urine, and this can cause seizure. And if this is severe and the child drank a lot of water, this can cause even death. It is rare, but it's very important to consider, very important to give this advice once you prescribe this medicine. Treatment of different cases of nocturnal enuresis. This is an excellent table for summarizing all different types of nocturnal enuresis. All cases, you need to limit the fluids before bed to less than or equal to 100 ml, void before bed, regular sleep and waking schedule. Classic primary monosymptomatic nocturnal enuresis. I like this name better than just nocturnal enuresis. The classic type, the primary type, alarm first, then desmopressin second. You try the alarm for at least 12 weeks, then desmopressin if the alarm failed. Nocturnal polyuria, desmopressin. Sleep disorder breathing, you need to do sleep study or x-ray, lateral neck x-ray. If the adenoid is large, refer to ENT for removal. This is by itself can treat nocturnal enuresis. A small bladder capacity, you need to give the alarm. Overactive bladder, desmopressin or oxybutynin. Oxybutynin antagonizes the acetylcholine. So if you have overactive bladder, this will relax the detorsor muscle. So this will relax the smooth muscle in the bladder by antagonizing the acetylcholine at the muscarinic receptor. It's called oxybutynin. It's an excellent medicine. Also, you can use the alarm and oxybutynin. So either desmopressin or oxybutynin, or alarm and oxybutynin together. Small bladder and nocturnal polyuria, desmopressin and alarm. Consider oxybutynin as well. This is a 12-year-old girl who plays field hockey and is in your office for a sports physical. She reports feeling well, denies any complaints, and has no significant past medical history. She is not taking any medications. Family history is significant for hypertension. She is a straight-A student, lives at home with her parents and 2 brothers who are healthy. Review of organ system or review of systems is significant for achieving menarche several months earlier. Physical examination shows her height and weight to be at the 50th percentile. Blood pressure was 136/82 high initially and was repeated with the same device 5 minutes apart, and is 132/78, is still high. She is a healthy appearing young girl who is comfortable and in no apparent distress. The rest of her physical examination was a normal limit. Because the blood pressure was high 2 times with the electric device, you decided to repeat the blood pressure with the manual auscultation, and it came back 128/77 millimeter of mercury. How you can decide the percentile for the blood pressure for this age? We'll know that in the next slide. The best way to determine the blood pressure, if you use the blood pressure curve, this is for boys, this is for girls. Our case is a girl, she's 12-year-old girl with blood pressure confirmed 128/77 millimeter of mercury. This is 12 and this is 128, so it is more than 95th percentile, so it is hypertension. Clinical approach to a child with hypertension. Step number 1, after the child has been resting for 5 minutes, make sure there is no clot in the arm. It has to be a bare arm, and you choose the appropriate bladder size. Too small will give you artificially high blood pressure, and too large will give you lower blood pressure. Step 3, if the blood pressure is high, confirm with manual blood pressure in 3 different occasions. If the blood pressure more than 95th percentile for age, gender, and height percentile, this is hypertension. It is very important to choose the appropriate cuff size before measuring a blood pressure. Too small cuff will give you artificially elevated blood pressure. Too large cuff will give you artificially low blood pressure. The cuff, it has bladder, and part with bladder and part without bladder. The bladder inside this tissue, and this tissue is without bladder, it's just to hold. This is the length of the bladder, this is the width of the bladder. So it's very important that the length of the bladder encircles at least 80 to 100% of the mid-arm circumference. Mid-arm is determined by the midpoint from the acromion to the olecranon. What about the width? The width size, it has to be at least 40% of the mid-arm circumference. Now the new bladder, they come with lines to make it easy for you to be able to determine the appropriate size. So you hold the bladder with both hands and measure and apply this line from here to here on the arm. If they are the same width, this is the appropriate bladder you will use for this patient. And you have here different sizes. Very important for the child to be quiet, not crossing legs, the arm to be at the level of the heart, and measuring blood pressure while the child is crying is not appropriate. Also, diagnosing high blood pressure in hospitalized children is not appropriate. It has to be determined in 3 different occasions in order to give the appropriate diagnosis of hypertension. Causes of hypertension in children: if it's before puberty, the most likely is secondary hypertension. The younger they are, the more likely they have underlying cause. After puberty, the most likely is essential hypertension. However, secondary hypertension can occur at any age. So bottom line, if you have a child with hypertension, you have to search for the underlying cause. Possible causes of hypertension in children according to the symptoms. If a child presents with chest pain, shortness of breath, palpitations, claudication, or murmur, think about coarctation of aorta, patent ductus arteriosus. If a child presents with weight loss, palpitation, sweating, flushing, weakness, constipation, fatigue, think about hyperthyroidism, pheochromocytoma, diabetes mellitus, congenital adrenal hyperplasia, hyperaldosteronism, hypercalcemia. If the child is having headache, vision changes, seizures, papilledema, abnormal neurologic examination, think about brain tumor, you will have exaggerated reflexes here. Guillain-Barré syndrome, you will have loss of reflexes. If the child is having rash, joint pain, joint swelling, fever, weight changes, think about systemic lupus, erythematosus, collagen vascular disease. Hyper or hyponatremia, hyper or hypokalemia, hypercalcemia, think about endocrine causes or genetic form of hypertension. Hyperlipidemia, hyperglycemia, low or absent plasma renin activity, think about metabolic syndrome, Cushing syndrome, endocrine or genetic form of hypertension. Echocardiogram can show coarctation of aorta, congenital anomalies in the heart dysfunction, pericardial effusion. Renal ultrasound can show renal mass, like in case of Wilms tumor, or neuroblastoma. Large kidneys, like in case of polycystic kidney disease. Small kidneys, like in chronic kidney diseases. Renal tubers, like in tuberous sclerosis. Horseshoe kidney, like in cases of Turner syndrome. Very important to review the medication history. Corticosteroids can cause hypertension. Decongestant and cold preparations we give to the children for common cold can cause hypertension and even stroke. So do not go easy with these medications. So be careful when you prescribe these medications and know the possible side effects. Non-steroidal anti-inflammatory medication like ibuprofen also can cause hypertension and even renal failure. Oral contraceptive pills, antihypertensive medication when the child stop and miss doses, this can cause hypertension. Beta adrenergic agonist, erythropoietin, and ADHD medications as well. Syndromes associated with hypertension: Williams syndrome associated with supravalvular aortic stenosis, mid-aortic syndrome, renal artery stenosis and renal anomalies, Turner syndrome associated with coarctation of aorta, renal anomalies and idiopathic hypertension, tuberous sclerosis associated with coarctation of aorta, renal artery stenosis and brain tumors, neurofibromatosis associated with essential and renovascular hypertension, polycystic kidney disease also can cause hypertension. Lifestyle change is very important in the management of hypertension in general. Weight loss if the child is overweight, 1 hour of moderate to vigorous exercise, decrease television watching and playing video and computer games to less than 2 hours per day, increase intake of fresh vegetables and fruits, reduce carbohydrate, fat and processed sugar intake, limit or avoid sugar sweetened drinks, salt restriction, smoking cessation if applicable. Management of hypertension, of course, the treatment of the underlying cause, initial therapy, calcium channel blockers or angiotensin converting enzyme inhibitors or ACE inhibitors. These two agents are very safe to use in children. Start with the lowest effective dose, increase the dose as tolerated to control blood pressure. If the blood pressure is not controlled, add another agent. Also, you need to know that beta blockers, the angiotensin receptor blockers, and diuretics are also acceptable first-line agents for the treatment of hypertension in children. This is the end of this presentation. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the last-minute review series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last-Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This video is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.